All right. Good morning. First of all, I want to wish everyone a happy Mother's Day. And so this is a case I actually wanted to share, and I just wanted to uh, focus this for the sake of our trainees. Uh, and so this is a 60-year-old uh, who was diagnosed with prostate cancer, and he came to MD Anderson for radiotherapy. And prior to radiotherapy, the team asked us to perform a colon cancer screening. So the request came as a colon cancer screening, and I assumed it was screening. And we did the screening, and this is what I'm going to share. So at the outset, I would like to thank my colleagues, Selvi, Sylvia, Ravi, Sriram. Roy couldn't join, and Joseph and Dr. Graham. Thank you. And I wish you all a happy Mother's Day. Because at the end of the day, without a mother, we are not here. And I want to acknowledge the support of my mentor, John Stoline, Mr. Charles Butt of HEB, and Angela Deal, medical illustrator, and my institution. So if you want to get your CME, please get registered. It's very easy to get the CME. It is free, so something to keep in mind. And let me take you through this case, all right? And before I take you through the case in terms of the screening colonoscopy, I wanted to share a couple of thoughts when it comes to screening. A lot of us, when I talk to young guys, they say, "Hey, I've done a colonoscopy," but when you want to do a screening colonoscopy, it is about two things. Your mental makeup to say to yourself that you are going to do the screening well and make sure that you will find the polyps that are there in that patient. And also your physical setup, the physical setup that would allow you to do a good exam, as well as do these exams for a long time without getting injured. So let me take you through these two things because I feel that these two things are very important. And let's talk about the physical setup. So one of the things that, there's so many different ways to do a colonoscopy. And I wanted to use a few diagrams to illustrate certain principles in terms of the physical setup. We all know about keeping the bed at a height that allows you to do the exam with your forearm at about right angles and your monitor to be about your eye level or just below the eye level. And the third thing is where you keep the patient on the bed, whether you keep the patient in the center of the bed or towards the edge of the bed. And I prefer to keep the patient at the very edge of the bed, and I'll explain to you why. So here I wanted to, I asked Angela to draw this picture to show the struggle of an endoscopist. As you can see, he's basically strangulating the scope to make the movements. And you could actually do the endoscopy without much struggle by doing one simple thing. And that one simple thing is step back. And if you step back, that will make a big difference in terms of your control of your scope, because as you control the control section of the scope in your left hand, in sync with the movement of the umbilical cord, both should be in sync. And if you could do that much better if you actually step back. And as you can step back a little further, you can actually use the torque of your body to do the rotation parts of the scope as you go around the circumference, inner circumference of the colon. And keeping these two things, I tell my endoscopy colleagues and also my trainees to take one simple step, that is step back. If you step back, your exam will be much easier. You have less stress on your body. All right. And the other thing that I would like to share with you is how you handle the scope. This is what happens if you're very close to the bed. You end up holding the scope very close to the bottom because there's no space. And the closer you are to the patient's bed, and the closer you're holding the scope very close to the anal canal, that portion of the scope becomes very rigid as it's coming out of the colon, and you have to use a lot more force to the point that you have to grip and put a lot of stress on your wrist and other things. And you could avoid that by taking that small step of stepping back. And the moment you step back, the scope actually becomes very floppy, and you could roll it in between your fingers to have a very good exam. And if you roll it in between your fingers with your right hand, and you make that movement in sync with the movements of the control section that is in your left hand. As you roll it to the right with your right hand, and you move your left hand towards the right hand, it's almost like if you have two hands on a circle, as the right hand comes towards the 5 o'clock, the left hand goes to the 11 o'clock. That automatically allows the scope to play in sync and makes it very easy. The other thing that I actually learned while reviewing videos for Video GIE, this was a beautiful video, and I want you to look at it. Published by Abbas. He's in San Diego, UCSD San Diego. They created two videos on ergonomic injuries. I think it's one of the most beautiful set of videos. And having a little bit of a gauze in your hand or a washcloth in your hand around the scope as you're withdrawing, you use less, it will be less stressful on your hand. So these are the principles that I would like to share, and is worth applying in your practice. Let me step back here, and I want Selvi to make some comments.
Thank you, Raju. So I think ergonomic injury is something that we're definitely hearing more and more about these days. It's especially, of course, useful and relevant for our junior colleagues who are just starting out in their academic practice or in their private practice. And they want to try to prevent injuries. So when you're learning things for the first time, or you're reinforcing early on, it's best to learn it the right way. That way, then you can carry forward the correct technique and try to reduce the risk of injury. For those of us who have been in practice for a long time, I am still of the mindset that it's never too late to teach an old dog new tricks. So I think some of these things that we can do will take more practice and more deliberate practice in order to incorporate these into the way that we've done, colonoscopy for 5, 10, 15, 20 years in some cases. So that's one thing. And the other thing is, I think we are hearing more about ergonomic injuries. If we look within each of our group practices, we can identify people who've had ergonomic injuries. So I think it's just a question of time before really all of us get impacted by an ergonomic injury. And there are a lot of, there's a lot in the literature, and maybe we can dedicate one of our sessions on Sunday to looking at the literature for ergonomic injury. But women are at a higher risk for ergonomic injury. And there's a really nice ACG grand rounds in the virtual education universe. It's free to all ACG members, where they have very detailed explanation of, ergonomic injuries and related to hand size and, muscle strength and all of those types of things that women are at an increased risk for ergonomic injury. And as we have more women entering the field of gastroenterology, happily, I think we need to really be aware of these injuries and how to reduce the likelihood of them happening. And then also, coming back from an injury and incorporating these changes into our practice so that we avoid re-injury or exacerbating injuries. Thank you, Raju.
Oh, thank you. Sylvia, Sriram, any comments?
Well, I don't have any special to add. I fully agree with Salve's very good tips. And I think we should learn early in our career about ergonomic injuries, not after we've got tendinitis or bad things. I think very early in our endoscopy training, we should increase awareness about the risks and try to avoid them as much as possible.
Sriram.
Yes, sir. Sorry. I don't know what's going on. Hello.
Yeah.
Is it any better now?
Yeah.
Yes. Yes.
Yeah. Okay. I'm a latecomer to the the ergonomics band, so I do have some injuries. So I try to adapt, and now what I do is in my own way, a warm up before every procedure. In that sense, for the small muscles of the hand and the shoulder and elbow. I think these injuries are of course, it is individual, but they are more pronounced for people who do all the variations of the procedures that are available for endoscopies. So if you do ERCP, US, EGD, colons, and over a long period of time, then you are accumulating different sort of injuries. So I think it is now I believe it is a very good idea before starting every procedure for spend a half a minute and doing some exercises for the small muscles.
What do you do?
There is a way, the video that Selvi talked about has some exercises, and there is also a small videos on the YouTube by one of our gastroenterologists. I forget his name. He's from Naval Academy. He put up some videos that are very, very good. I can send the links a little later.
Okay. Ravi.
I think I agree with all the points raised. If I were to say, when I started as a fellow, the first few things which I noticed is that the thenar muscles in your right hand starts to hurt. And when you kind of like don't handle the wheels properly, you start developing callosities in your left thumb. And if your screen height is not proper, end of the day, you all develop neck pain, shoulder discomfort, and so on. A lot of times we don't pay attention to this, and then we always want to just do our procedures. But I think that's not a good idea. Then first thing is, when you start noticing these things, it's always better to sit back and think, why is this happening? And then you kind of like look back into whether my technique is right, whether the setup is right. And then there are amazing resources which Deep has also put up, which would be helpful to look at. So nowadays, I think the time you start recognizing the way you hold scope, the way you talk, steer, all this actually I kind of like changed, and the callosity starts to disappear. And secondly, if you have a long list like morning and afternoon, it's very important to actually take a short breaks between like couple of endoscopies. Just do some stretches for your fingers and then come back. It doesn't have to be long, like even a short like 5-10 minutes break in between actually helps a lot. I think that's what I do. If there is a long list, I don't like continuously try to do it. Otherwise, end of the day, your neck really starts hurting. So to a certain extent, having a good setup, arranging your screens properly, informing your nurse about what you want, what level you want the bed to be. These are all like simple things that we can adopt every day to help us.
Thank you, Ravi. Sammy actually put in a chat saying that I usually put the patient on in supine position, so the weight of the scope is on the table, not on my hand. What do you think? Sammy, I don't know much because that's a technique that I've not practiced. Maybe you could comment and share with us, how it works for you. I think one of the things that I do is when I make the patient from left lateral to supine, which happens maybe once in a while, then basically what's going to happen is you have to rotate yourself from almost 45 degrees to the left, so that your hand is going in between the patient's legs to reach the scope. And if I do that, I make my monitor also uh, I move my monitor to the left so that it is in front of me, straight ahead, and not and I avoid looking to the right when I turn to the left, because that would unnecessarily put strain on your body. So if I put a patient from left lateral to supine, I move my monitor, which is in front of me when I'm doing left lateral position, a little bit to the left side so that I can see straight ahead without turning my neck. All right.
I think that's an important point, Raju. Whenever we have to change the position of the patient, I think we have to kind of stop and then reevaluate the whole situation, not just the monitor, but for if you're short like me and I'm trying to look over the patient's bended like knee, then the monitor height needs to change, the bed height may need to change, all of that.
Right.
So you have to kind of do a reset whenever the patient's position changes. Hopefully that doesn't often happen too often.
Right. So I hope that is helpful. Sammy, maybe you could comment later on or in the chat, or if you want, you can interrupt and comment. So the other one is, I talked about the physical setup. The second one is the mental makeup. When I say mental makeup, as you can see here, most of the scopes, the light that comes out of the scope is not necessarily uniformly illuminating the whole lumen, right? It illuminates a section brighter and the other section is not so. So when you're scoping, you have to ask yourself whether you could use the bright light and examine the entire colon, right upper quadrant, right lower quadrant, left lower quadrant, left upper quadrant in a circumferential manner. So by doing that, you will have, you would examine the entire colon. Even if you have AI incorporated into your practice, AI cannot see what the scope don't see. So you have to keep in mind, at the end of the day, your technique of examining the entire surface area of the colon is critical. And when you have that as part of your practice, the AI will help you, because if in case you are not focusing in a certain area, AI will highlight that area. And that's why don't think that if you have AI in your practice, you can just push your scope in and pull the scope out. That is not going to work. So I just want to put here as a small segment of examination of the cecum and ascending colon. I felt that when we say, hey, how do we examine? You want to examine it like I'm doing it and asking myself, okay, did I examine this lower portion, this left lower quadrant, right lower quadrant, and if there is a fold, I may have to go back in again and then try to use my cap to open it up. And then I always ask myself whether I have examined the area between the cecum and the opening of the ileocecal valve. And for some reason, it got stuck in my mind because I read about a legal case where somebody said you didn't examine that portion. That's why the patient developed cancer in that area. So it's important to examine, as you can see, in a circumferential manner, and to use water to clear. And then you may have to examine segments multiple times so that you get a good examination. And you ask yourself, okay, did I examine that fold in between, that area in between those folds down below? If not, you go back and examine. And by having a cap at the end of the scope, it helps you to define and examine areas that you would otherwise have difficulty. As you can see here, we're coming back and then you're going back again in to examine areas that you may not have examined. So something to keep in mind. The other thing is to not only examine when the colon is fully distended, but also after a little bit of deflation, which allows you to find polyps that have otherwise become very flat. And as you can see here, I see a polyp and I'm rotating my scope. And as you can see, my light is most intense in the lower 1/3 of the field. And I'm trying to define that polyp by putting an MBI. And you can see that this was a tubular adenoma and it's quite flat. So something to keep in mind, and we're going to see a little better and then consider doing either a cold snare resection or an EMR, depending upon the features. So now you can see a little bit better. It's a flat lesion, and it's a small lesion. It's probably anywhere between 2B or 2A. And once I put the NBI, you will be convinced that this is a tubular adenoma, like we did before. Sylvia and Selvi, do you agree that it's a tubular adenoma?
Yes, it's a tubular adenoma. Just maybe, may I have a short comment?
Yeah, please.
I think I really enjoyed the point you made about the blind spots. Indeed, there are studies, the post-colonoscopy colorectal cancer data, showing that post-colonoscopy cancers can occur in all segments, but in particular, there are two locations for some reasons we don't inspect adequately in some situations, and these are the cecum with area you have described between the ileocecal valve and appendiceal orifice, and the second is the rectosigmoid junction. If the angulation is if there is a tight angle, it seems that we may miss lesions, especially of course when they are flat and inconspicuous. So these two areas should be examined properly.
Yeah. All right. So the other thing that I want to share is you can see here. Sometimes what happens is, as you're doing the case, this is an extension of the same patient. and he had a lot of debris. And when I see a lot of debris, one of the things that I started doing is take the water jet that is hooked to the umbilical cord, attach a blunt needle, and put it in the biopsy port and use that water jet, because that water jet tends to be uh, a softer, kinder jet, which doesn't create a lot of bubbles and allows us to examine areas where there is debris that you cannot necessarily suction. So we do see a lesion. I don't see Zubair here today. Maybe Joseph can comment on this. I think Joseph's, I don't know, Joseph may not be on with his mic. So Ravi, what do you think?
Well, this is very interesting lesion. The size of the lesion is not that big, but what catches the attention here is the central portion of the lesion. There appears to be a depressed looking area there. And the periphery of the lesion, if you see, it's not like a normal looking polyp, but it looks like it's expanded to some extent. And at the top part, the two folds are kind of like coming closer to the polyp. So all these are suggesting that this is not going to be a polyp that is that simple that we expect or that we see every day. So we need to inspect it in more detail. So I would want to like go and evaluate the central area, which is the depressed area more with the dye, and then we'll also use narrowband imaging to see how the vascular and surface pattern is.
Right. So here we go. I'll let you keep commenting. So near focus.
The lesion is brown in color so far, which is consistent with an adenoma, but I don't seem to appreciate the vascular pattern in the center of the lesion.
Yeah.
J'aurais aimé me lever à 10h ou 9h non-stop, pas me lever à 6h comme ça.
Any thoughts, Sylvia?
I fully agree with Ravi's description. This is a subtle lesion. It is a 2A 2C. I'm not sure it's a true depression. The margin of the depression should be abrupt in order to classify it as.
J'ai vérifié les robinets à la maison ce matin. Je suis passé.
Ah, pour le
jardin. Pour le jardin. Bon, j'ai pas tout vérifié. Du côté des voitures, je sais pas, il y en a sûrement. J'ai pas vérifié.
Tammy, could you mute your mic, please?
Yeah.
We were in a French session all of a sudden.
Yeah.
I was not sure. So yes, I agree that this might be a lesion with at high risk to contain submucosal invasion. So I would apply.
What do you think now?
Yeah.
In my opinion, but I can't assess the central area very well.
Right. So when I saw this, I actually was a little bit. I worried whether I'm dealing with an advanced lesion beyond a tubular adenoma. You know, like Ravi and you pointed out, it looked it had a little bit of submucosal swelling, and there's a little bit of central depression. and the two folds coming there um, made me wonder whether this is a an advanced adenoma, maybe an early cancer. That's what I thought. And although, we started with a cold snare and resected a polyp higher up and another polyp before this, and this could have been resected with a cold snare. But when I saw those findings and made me worry about possible cancer or something advanced beyond an adenoma, right? So I thought it is better for me to do an EMR. And I'm sorry, Ravi and Sylvia, I didn't do a dye spray. Usually when I see something and I'm suspicious about that, I use the injection to help me define whether the submucosa is free or not. And if it lifts well, I take it that at least the middle and deep submucosa should be free. So as you can see here, I didn't inject through the center because of the suspicion. I injected a little bit to the other side. And then the next one is I injected below to get a good lift. And that lift made me made me a little more comfortable, thinking that, okay, we're not dealing with a deep invasive cancer, but whatever it is, still those folds were worrisome. And I felt that I should do an EMR with a traditional hot snare rather than a cold snare. So we decided to use a hot snare. And as you can see here, we talked about this technique, I think a couple of weeks back when Roy talked about, using the snare to flip and then get it. So the injection went well, and it is facing us. The snare came out at 90 degrees. And then you can anchor it and then try to see if you can get en bloc resection with a little bit of a margin. And we are able to get a nice clean margin. And then a little bit of guesswork, as you can see, when I'm closing the snare. And then I rotate it and able to close with a nice margin around. And then we use the hot snare, Endocut Q313 to cut this polyp. Although, this is a small polyp. Sylvia, what do you think is the size of this polyp?
I think it's less than 1 centimeter, maybe 8 millimeter. And I used to subdivide the circumference in 4 quadrants. And one quadrant would correspond to about 2 centimeter. So in my understanding, this is smaller, it's smaller than a quadrant, should be something like 1 centimeter. Max 1 centimeter, even less.
Right.
What do you think?
Right. I thought it was probably about 7 millimeters or 8 millimeters. That's what I thought.
Yes.
And we always think about, okay, we say, okay, 5 to 10 millimeter or 4 to 9 millimeter lesions or 10 millimeter lesions, flat lesions, you could go ahead and resect with a cold snare. That's what most of the guidelines suggest. But it's important to look at the polyp and ask yourself, is this polyp looking like a regular traditional benign polyp with no odd features? And if that's true, then I would have done a cold snare rather than spend this time to inject, lift, and cut. But in this case, the polyp looked a little bit odd. You agree with that, right? The polyp looked a little bit odd because of the converging folds. The surface looked a little bit odd. Although I didn't see the vascular pattern, despite using the near focus to make me worry about cancer, but because of the surrounding folds, I felt that it is better to do an EMR rather than cold snare resection. So I would like to stop here and ask for any comments, what each one of you would do in a case like this.
I just have a short comment. I think this is a very nice case to illustrate that classifications are not perfect, and especially when it's about small lesions, it is sometimes difficult to classify them. But through submucosal, applying submucosal injection, we stretched the lesion. We call it umbrella sign, so we could better appreciate the epithelial surface. And we all had a suspicion that this is a high risk lesion. So it was not, we couldn't objectivate the depression, but we all agree that this is quite weird lesion, and we would not take the risk of performing cold snare polypectomy in this case. And why? Because a depressed lesion, as we know, is rare. We find in less than 1%, actually in our experience 0.4% of the lesions were depressed. But if they are depressed, truly depressed lesions, they are associated with 60-70% risk to contain high-grade dysplasia or submucosal invasion. So that is why we don't want to take any risk in such cases.
Oh, thank you so much. That's beautifully said. Sriram.
Not much to add, sir. Only thing is that if it is, I was just wondering, once after you inject, I agree about the cold snaring without lifting. But once you lift, and if it is 6-8 millimeters polyp, I was just thinking loud as to what would be the difference once it lifts very well, and if I'm able to get a good margin, why can't I remove it with an X-Acto? What additional benefit would it give with the hot snare? And also, if at all there is something in the margin, in the vertical margin, the lack of cautery effect might give me a better Haggett's interpretation than if at all there is a focus of cancer in it. But I'm not suggesting this as to be done, and what Sylvia mentioned holds true for all lesions, but I'm just thinking loud as to, in a small lesion which lifts, how is it the heat or no heat makes a difference in terms of the outcome?
So, all right, let's shall we comment on this, and then I'll comment. Sylvia, and shall we comment on that?
I fully agree that a small lesion, less than 1 centimeter in size, and well, can be also removed by cold snare. The most important thing I would focus is to capture it for pathology examination. So that would be my next thought: how to focus to capture the lesion, to retrieve it in order to have full pathology.
Yeah, precisely. That is my point, and I agree with that. Like, as long as once I'm able to lift, that means I'm able to lift it out of the submucosa, and once I resect, then the focus should be on how to capture it without macerating it through the suction channel.
Yeah. So I think you have a point whether we should cut it in cold or hot. The reason I went with the hot was there is with the hot, I felt that I could get a much cleaner cut and I can examine better because there's not going to be any bleeding. And the second one is, although this may not apply here, just for the sake of information to others, there is a study where people compared hot snare versus cold snare, resection of small polyps. The difference in terms of histopathology is with cold snare, you may not get, you're unlikely to get muscularis mucosa in the specimen uniformly. So that's one thing that they've actually talked about. You know, if there is any concern And if you want to get a better specimen, it's better to go with a hot snare instead of cold snare. But that study was not comparing the use of submucosal saline injection to lift. It was just
Yeah,
cold
that is my point.
Right.
That is the only point. Otherwise, I am not
Yeah.
even
Right.
making a conversation about it.
Right.
It's not about cold versus hot, but it is about cold versus hot in the setting of after submucosal injection. That is for an EMR for a small lesion.
Right.
Exactly.
All right.
One other aspect is the depth. Like in this case, I think submucosal injection helps in two ways. One is achieving a good lift, is reassuring, saying that the depth of invasion may not be very deep to some extent. And second thing is, in terms of using hot or cold snare, I think there was a study which was published in GIE, which looks at the percentage of muscularis mucosa resection in with injection and without injection cold snare. I think if we do cold snare even with injection, we are not going to capture that much of muscularis mucosae. I think it's less than 50%. I shared the study in the chat group. Rather, if we use a hot snare, I think we can be certain that the amount of submucosa that we clear for pathological evaluation would be adequate with the hot snare as compared to cold snare. So like in this lesion, you would want to give a good amount of submucosa for the pathologist to assess so that we can understand what's the depth of invasion and so on. So I wouldn't attempt cold snare in this case with or without injection.
Yeah. So that's good. The other thing is, when you have a suspicion like this one, right? As I was doing the case, I worried about, hey, am I finding a cancer in a guy who's waiting for his prostate cancer radiotherapy, right? And you want to make sure that this is a case where you have to end up, even though it's a small, it lifted nice, and you feel that this is probably not a cancer because of the good lift, it's a good idea to tattoo that. So we decided to put a tattoo. Normally, I don't do this, but in this case, because of my own concerns about potential, even if there's a 1% or 2% chance that this could come back as cancer, although I doubted that with the good lift, I just took that extra precaution of putting a tattoo there. So something to keep in mind. So what is your guess? I don't have the path specimen, but actually this is a case that I did it in 2018. And I went back and looked at the path, when I say path report. So I'll let you all guess what is the path specimen going to show. Tubular adenoma, serrated adenoma, hyperplastic polyp, tubular villous adenoma, high-grade dysplasia, or early cancer. So let me start with Selvi and then go down.
So my guess is tubular adenoma with focal high-grade dysplasia.
All right.
Especially that central part that looked concerning to everyone.
Okay.
Same for me.
Okay.
Tubular adenoma with the focal high-grade dysplasia.
Okay. Ravi.
Same, high-grade dysplasia or T1.
Right. Okay. Sriram. Joseph has already commented.
Well, now that everybody committed for hybrid, I would say it is just
to be different.
No, otherwise there has to be a variation for conversation, right?
Right.
We thought
Right.
that
Like,
you will ask artificial intelligence.
right.
Okay. All right. That's what it is.
Yeah, margin clear because the high grade is just in the middle. Where's the high grade?
There's no high grade.
No.
So, but I want to share this thought. To me, once you cut and you cut it right, as long as the muscularis mucosa is intact, what is above in that compartment really doesn't matter. So I want you to guys discuss that, whether I'm on the wrong footing or, I really don't care what it is, as long as the muscularis mucosa is intact, whether it's tubular villus, with or without high-grade dysplasia, or even intramucosal cancer.
So that's the deep margin, right? That you're talking about. You don't care, but the peripheral margins are obviously still important. I mean, in your resection, it looked beautiful and it looked clear to the eye.
Right.
And when you're saying margin clear, if that includes the peripheral margin all around the lesion, then I think that's fantastic.
All right. I was just thinking through what were my comments earlier, and then quickly looked at Ravi's the article. I think that it makes sense in a different way. When you inject in submucosa, you do not know at which submucosal plane you are injecting and lifting the lesion. And maybe that is the reason why the submucosal injection fared not uniformly well, in fact, inferior to cold snare resection. That article is not about cold snare versus hot snare EMR, but it is about cold snare resection versus cold snare EMR, meaning submucosal injection, comparing just plain cold snare with cold snare after submucosal injection. And cold snare after submucosal injection in small lesions, which are 3 to 10 millimeters, fared poorly than straight cold snaring. Probably it makes sense because if you are not lifting, you are capturing more vertical tissue when you are cold snaring. And that is probably the reason why the muscular mucosa gets more of muscular mucosa is involved in cold snaring rather than with after submucosal injection. I just wanted to clarify that part. And the other observation is that in this lesion, before the injection, it looked like there is depression there. And that is what actually prompted all of us to think there is something more than just a tubular adenoma. But after you injected, the whole, that flatness, that depression has more or less disappeared, although there is some baldness in that area. So I don't know too much about the surface characteristics, and so I can't comment too much, but I thought it's just an observation.
So let me ask a question, Sylvia. Is it more effective to characterize the lesion under NBI prior to injection, or is it more effective to characterize it after injection?
Let me add one more question to that. Yeah. So Sylvia can comment on both. She knows these things more.
Yes.
So traditionally, when you are commenting on the surface characteristics, are all these studies are not after injection, right? These interpretations, do they hold true even after submucosal injection?
Hello?
Yeah, go ahead.
Yes, please go ahead.
No, you go.
Did you get Selvi's question?
No, yes, I've got Selva's question, but I didn't.
So I wanted to add on to that to say that the studies on the surface characteristics interpretation of the pit patterns and all, do that interpretation hold true even after submucosal injection, or are these only traditionally before submucosal injection?
Yes, I think that this is a difficult to answer question. In my opinion, the limiting factor to assess the epithelial surface, an important limiting factor, is the size of the lesion. The smaller the size, the less precise is our evaluation, our diagnosis of the epithelial surface changes and the pit pattern. And I think this was a very small lesion, and I fully agree that after submucosal injection, it was completely stretched, so it was no depression anymore visible. And regarding the application of imaging image-enhanced endoscopy before or after, I do them both. I think at the first sight, I get orientation. I use the image-enhanced endoscopy to assess, if possible, the epithelial surface. And after submucosal injection, I take a last look, like a confirmation whether or not the best therapy is, in this case, EMR, or maybe should be surgery whatsoever. So to answer your question, I do them both, but it's not like not it's dependent upon the lesion, and small lesions again require more attention. I do it a few times to make sure that's the right diagnosis. Does this answer your question, Selvi and Ravi?
Yes, thank you. Thank you so
Yeah, thank
much.
you so much. Thanks.
Any other comments?
Actually, what we have observed in our training of, so we have trained our trainees to perform optical diagnosis. We have used optical diagnosis with Pentax eye scan and similar principles like the NICE classification with MBI. The point I want to make is that after 1 hour of training, intensive training session, they managed to differentiate between adenomas and serrated polyps with accuracy of nearly 90%. But the last 10%, these are very difficult to achieve. These need practice and deliberate practice with feedback and evaluation of the histology, revision of the histology. So it seems that we learn quite fast to predict histology with accuracy of 80-90%. And this is actually confirmed by randomized controlled trials by the St. Mark's trial with MBI. But the last 10% are very difficult. This requires a lot of practice. And of course, how much practice, we don't know exactly a number. It may differ between endoscopists. Some of them may have better abilities to differentiate, but it's a matter of practice and a lot of practice. And if Roy would be here, probably he will tell us that deliberate practice is key.
All right. Thank you so much, Sylvia. I just wanted to share something. Actually, to be honest with you, this is very interesting. So when I was seeing this gentleman, and before we started the procedure, he asked, why are you here? And I said, I'm coming here for screening. And then I assumed that it is screening. And then we put the procedure as screening. For some reason, he was stuck in the battle between the insurance companies, whether they would pay for that procedure or not. And it's also interesting that later on, he sent me a message saying that, you put my report wrong. It should not be screening. It should be high-risk screening, because I had a colonoscopy 5 years back and I was found to have polyps. So I basically put an addendum to the report. And when I was looking through his record yesterday, as I prepared for this discussion, I was looking through all the conversations that happened from the time we did the procedure till his bill was settled. It took almost a year.
Oh boy.
And as you can see, the frustration from him trying to get this thing resolved for no fault of his, despite the fact that we made an addendum to the report. And partly because, we thought that, okay, when we asked him, okay, you had a procedure done before. And then when I was looking through the records, I see a referral saying colon cancer screening, blah, 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 blah. So something to keep in mind, when people get stuck in the middle, and payments need to be cleared, it may take a long time. And unnecessary hassle to the patient. All right.
The other side of the coin is also important to remember that colon cancer screening colonoscopy is not there's no copay for most of the insurances. Whereas if it is wrongly coded as diagnostic for whatever purpose, because the referral doctor said that he had rectal bleeding, hemorrhoidal bleeding, and we say rectal bleeding and diagnostic, then the patient gets a bill for copay. Whereas the hemorrhoids may not be the reason why we are doing the colonoscopy, but it is the screening.
Yeah, thank you. Thank you. All right, any other last minute comments? Selvi?
No, Raju, I think this was a good case. Thank you for presenting it.
As always. Thanks a lot.
Right. Sylvia, you want to summarize?
Well,
Your summaries are the best. So
yeah.
we need to hear how you summarize. We can learn from that.
So my take-home messages for this case would be that macroscopic examination of a lesion is very important to predict the histology and the best therapeutic approach. In this case, the patient had a very subtle lesion. We suspected presence of a depression or pseudo-depression. And instead of going first from the very beginning, because it was a small lesion, going for a cold snare, we were very cautious. We injected the lesion, better appreciated the epithelial surface, and performed EMR. I have learned again that classifications are not perfect, but they guide us in our diagnosis and decision for the best therapy. So we should still use them. They are communication tools rather than strict classifications. And in this case, my take-home message is that recognition of these subtle lesions requires a lot of practice. It takes me back to a paper from Roy's group. I think McGill and McGill is the name of the authors, and published in GUT, I think 2015, and they have shown the learning curve for detection of non-polypoid colorectal neoplasms. And I still remember the figures after 200 colonoscopies. So they received the training. The 4 gastroenterologists at Palo Alto were trained in recognition, trained in Japan in recognition of non-polypoid colorectal neoplasms. After the first 200 colonoscopies after training, the detection rate went from 1.5 to 3%. After 600 colonoscopies, the detection rate went from 3 to 4.55%, but it took more than 1,000 colonoscopies to reach a 7.8%, 7 or 8% detection rate, which is common for non-polypoid colorectal neoplasms. So that means we need a lot of practice in order to recognize this subtle lesion. Bowel preparation is very important, and careful, meticulous inspection, not only the withdrawal time, but the withdrawal technique is important to detect these lesions. And the last but not least, these are most likely these are the most important contributor to post-colonoscopy cancer. So that is why it is important to pay additional attention to recognition of non-polypoid colorectal neoplasms.
That was excellent. May I add one point, Raju?
I enjoy listening to Sylvia.
This is amazing. I love it. I love it. May I add one point quickly?
Please.
The last point is what you started the presentation with, which is ergonomic injuries and awareness of that. And so I would just encourage all the physicians to advocate for themselves and just remember that ergonomic injury is not the exception to the rule. Everybody gets affected. Nobody is, resistant or impervious to this. It will happen to everybody. So we just need to be aware and advocate for ourselves. That's it. Thank you.
Thank you so much.
Thank you. Hope you all have a great Mother's Day. Thank you so much. Thank you.
Thank you so much.
Thank you. Bye, everyone.
Bye bye. Bye bye.
Okay, cheers.